I would like to address my first question, if I may, to Dr. Hine. You note that more medical training must have greater flexibility if we're going to increase the presence of primary doctors in our healthcare system. How do we go about accomplishing this goal in a balanced way without creating new challenges for our medical education system?
Thank you. If I understand your question, are you asking how do we balance the number of slots or the types of specialties that people go into, ma'am?
Well, you're saying that we need more medical training, and in order to achieve that we must have greater flexibility if we're going to increase the presence of primary doctors. What I'm asking is, how can we achieve that goal without impacting or dismantling or affecting or posing new challenges for our medical education system?
The slots that we have right now, we have asked that the numbers of slots available for training in residency programs, those right now are, as you noted in your remarks, being primarily, most of the education is done in the hospital. So there are a couple of factors. One is we have to realign the actual slots for training so that more of those go to primary care. That's a redistribution issue. Mm-hmm. The other component is then paying for the care that is done in the community. Part of this is a regulation change that can occur at CMS having to do with voluntary preceptors. The third component is that we believe that right now funding for training is primarily through government products, Medicare, Medicaid. Our policy is that everybody should contribute to that, whether or not it's funding for any of the GME slots. And in that way, then I think it becomes much more balanced.
Dr. Sheldon, do you have any thoughts on that?
Well, I think the Balanced Budget Act in 1997 froze reimbursement under Medicare, and that needs to be taken off. It's important to note that there's only 4 specialties have more applicants than they do slots. And when you talk about unfilled slots, most of those are in primary care fields, and redistributing back to primary care, I don't know if that would solve it or not.
Dr. Harbert, the shortage of physicians is expected to intensify if health reform passes. As we learned in Massachusetts, there is no guarantee that patients will be able to see a doctor if they have health insurance. How do we avoid this problem to ensure access to care doesn't become a major problem?
I think all of us have addressed that there clearly is a shortage of physicians, and that includes primary care physicians, but certainly is not restricted to primary care physicians. There are acute shortages of surgical specialists, and we can't simply say we have to shift everything to primary care and that will take care of the problem, because it will exacerbate the surgical shortages. There's some of the things that I think would be very helpful. One would be to revise the cap on Medicare support for resident training, and that is an important issue. We're creating more medical students right now. There's a lot of investment going into new medical schools, enlarging medical school classes, but if we don't enlarge the residency training pool, we're simply going to take students that are trained in the United States, and they will displace students that are trained in other countries' medical schools that now do their residency training here. And at the end of the pipeline, we will have the same number of doctors coming out. So increasing the number of medical school slots without residency slots doesn't help. And I think we have to recognize that that increase must go across all specialties. We can make things worse by focusing solely on primary care and now having an exacerbated crisis in the surgical specialties, a crisis that already exists.
There's no easy solutions, right? I would like for any of the members of the panel to respond to this question. Medical liability is a major concern for the medical profession. It seems clear that health reform cannot be achieved without addressing this issue. Short of placing a cap on medical claims, the President has stated he believes this should be addressed as part of reform. What measures should Congress consider to reduce the costs of malpractice insurance? Dr. DeMarco, let me.
Next to caps, except for caps. Well, unfortunately, the caps are a great part because industry knew right away in the early days that workman comp, they knew how to deal with set their prices the way they needed if there was injuries. But without caps in Texas, for instance, when they passed the law on caps, the malpractice insurance dropped by 12.5% the next day. And now it's down by 25% since the passage of caps. So I think the caps are an important part of physician liability reform, and that is necessary to attract students into specialties that reimburse less.
Okay. Dr. Schultz.
I think the only answer is a cap like the California law. 3 years ago, West Virginia's liability got so high that all the acute patients with trauma had to be transferred to Pennsylvania by helicopter. Same thing happened in Nevada. An emergency session of the legislature was called to provide some. It won't work unless you cap like California did. And we appreciate the House has passed this many times. It's the Senate that doesn't seem to like it.
Yeah, I mean, I think the caps are an important piece. Other things that could be considered would be alternatives to civil litigation, early disclosure, compensation offers, administrative determination of compensation, where you'd have a health court model that would determine compensation. I think we can also do things like provide medical liability protection for physicians who follow established evidence-based practice guidelines. If you're practicing to the standard of care, even if there's a bad outcome, then that shouldn't be a liability issue. Some minor things would be to protect physicians who volunteer their services in a disaster or local emergency situation. And I think going back to the cap, some reasonable cap on non-economic damages, not on the economic damages to the patient, but a cap on non-economic damages is a very important piece of the puzzle.
Dr. Carl.
The other piece is that in Kansas there's an equalization pool. My neighboring state in Missouri, it's present but not funded. I pay as much in doing no procedures as a gastroenterologist who is licensed in Kansas who does procedures all day long. There needs to be more equity in the way the premiums are determined.
Okay. Thank you. Now I recognize Ranking Member Graves.